Lecture 2. I'm going to review briefly the epidemiology. Systemic reactions to insect stings can occur at any age, after any number of uneventful stings. They tend to be more severe in adults, about 3%, and 1% of children. Up to 25% of adults may show some IgE to venom components. 2 million venom allergic people exist in the United States, so approximately 200,000 in Canada. 30 to 50 deaths a year also are attributed directly as a result of venom anaphylaxis in the United States. Fatalities are most common among adults, 40 to 69 years of age. 1/2 of fatal reactions occur in individuals with no previous history of serious reactions. Classifications of insect sting reactions can really be classified as normal. These are immediate, local, and transient. Large local. These tend to be delayed, prolonged, and progressive. Systemic, which are immediate, generalized. Other reactions such as toxic, serum sickness, and neuropathies can occasionally occur but are much more rare. Toxic and unusual reactions occur commonly after multiple simultaneous stings, often to Africanized honeybees. Guillain-Barré seizures, rhabdomyolysis, and delayed cold urticaria are also found to be reported by Moffitt et al., Journal of Allergy Clinical Immunology 2004, and Reisman and Robert in the clinical monograph. We're going to focus on the systemic reactions. Risk of systemic reaction in untreated patients with a history of positive skin tests are shown in this table here. Now the diagnosis. History is critical. Skin tests are more specific than serum venom-specific IgE. After a skin reaction, skin tests can remain negative for 4 to 6 weeks following a sting. It is important to retest if a patient initially tests negative after this refractory period. Negative skin tests may also represent loss of sensitivity with distant history of sting reaction. So the order is skin test, in vitro test, and possibly repeat skin tests, and wait at least 6 weeks. Skin test size or concentration of IgE does not correspond to severity of reaction. Approximately 20% of skin test positive patients have negative in vitro specific IgE, and 10% of positive in vitro specific IgE have a negative skin test. In JACI 1990 by Lockey et al., over 3,000 patients were studied. This confirmed that the degree of severity did not correlate with 1. Severity of most recent sting prior to the entry into the study, 2. The most severe historical sting systemic reaction, 3. The most severe systemic reaction during venom skin testing, and 4. Total dose of venom, 5. Degree of skin test reactivity, and 6. The lowest concentration of venom yielding a positive skin test. Indications of sting insect immunotherapy is something that you should all know, particularly for licensing exams. This is classified by classification of sting, reaction by history, venom skin test, and immunotherapy. You see that generally, large local reactions, skin testing and immunotherapy is not recommended. However, there is a caveat of very large local reactions in recent papers out in the last year. Systemic reactions in children is more than generalized urticaria. The cutoff age to define children is under 16 years. That is a key distinguishing factor between children and adults. This is because most children with urticaria do not go on to have risk of systemic reaction that is greater than that of the general population, as seen in the previous table shown. Allergen venom extracts are used to constitute vaccines or venom immunotherapy. They are generally specific to the species. Mixed vespid includes yellow jacket, yellow hornet, and white-faced hornet. These are for the patients that generally tend to test positive to all of these because of some cross-reactivity and/or multiple sensitization. The dosing regimen interval between injections can vary depending on the protocol. Once you reach maintenance phase, maintenance injections are recommended every 4 weeks for 1 year, and then every 6 weeks for subsequent years. In some cases, injection intervals can be spread out to every 2 months. This is generally done after 4 years of maintenance or longer. The general maintenance dose recommended is 100 micrograms. This equates to 300 micrograms for mixed vespid. What I typically do in my practice is the modified rush protocol shown in the ALK Abello package insert. This achieves a quick maintenance in 8 weeks over traditional venom scheduling intervals. There is no evidence of difference in side effects with the cluster rush modified protocol.